Heart failure. Question 1. Define heart failure and classify it comprehensively. Model answer. Definition. A clinical syndrome due to any structural or functional cardiac abnormality causing impaired ventricular ejection or filling. By left ventricular ejection fraction, or EF. HF-REF, systolic heart failure. EF less than 40%. HF-MEREF, EF between 40 and 49%. HF-PEF, diastolic heart failure. EF greater than or equal to 50%, symptoms and signs of heart failure with preserved EF. By side, left-sided, right-sided, biventricular or congestive heart failure. By time course, acute, chronic, acute on chronic. By output state, low CO heart failure, usual, high CO heart failure, hyperdynamic states, anemia, thyrotoxicosis, wet beriberi. By clinical, overt versus latent. Latent, compensated, versus overt, decompensated. Functional severity, New York Heart Association. 1. No limitation. 2. Slight. 3. Marked. 4. Symptoms at rest. Structural or trajectory, the American College of Cardiology and the American Heart Association stages. A. At risk. H. Tension, diabetes and coronary artery disease with no structural disease. B. Structural heart disease. Decreased EF, left ventricular hypertrophy, chamber dilatation. No symptoms. C. Symptomatic heart failure. D. Refractory heart failure needing advanced therapy, cardiac resynchronization therapy, left ventricular assist device, or transplant. Diagnostic rule-in set. Heart failure equals at least 2 major or 1 major plus 2 minor. Major, paroxysmal nocturnal dyspnea, neck vein distension, rales, radiographic cardiomegaly, acute pulmonary edema, S3 gallop, central venous pressure greater than 16 centimeters, water, hepatojugular reflux, weight loss greater than 4.5 kilograms per 5 days with RX, minor, bilateral ankle edema, nocturnal cough, dyspnea on ordinary exertion, hepatomegaly, pleural effusion, decreased vital capacity by 1/3, tachycardia greater than 120 beats per minute, MCQ high yield, HFrEF less than 40%, HFpEF greater than or equal to 50%, stage A not equal to NYHA1, axes differ. Framingham equals clinical criteria, NPs help but are not in the score. Question 2. Etiology, left versus right, and systolic versus diastolic. Include 3x3 patterns. Model answer. Most common. HFrEF is ischemic heart disease, worldwide number 1. HFpEF, long-standing systemic hypertension with concentric left ventricular hypertrophy. RHF, most often secondary to left-sided heart failure. Left-sided heart failure. Left atrial failure, mitral stenosis, left atrial myxoma. Left ventricular failure, 3x3. 1. Muscle disease, myocardial infarction, myocarditis, cardiomyopathy. 2. Volume overload, increased preload, mitral regurgitation, aortic regurgitation, ventricular septal defect, patent ductus arteriosus, hyperdynamic circulation, anemia, hyperthyroidism, beriberi. 3. Pressure overload, increased afterload, systemic HTN, aortic stenosis, coarctation of the aorta. Right-sided heart failure, right atrial failure, tricuspid stenosis, right atrial myxoma, right ventricular failure, 3x3. 1. Muscle disease, as in left-sided. 2. Volume overload, tricuspid regurgitation, pulmonary regurgitation, ventricular septal defect, atrial septal defect, hyperdynamic states. 3. Pressure overload, pulmonary hypertension, pulmonary valve stenosis, pulmonary embolism. HFpEF, diastolic, stiff ventricle causes, HTN, AS, hypertrophic or restrictive CM, old MI, scar, aging, diabetes, myocardial glycation, sarcoidosis or amyloidosis, constrictive pericarditis, high output heart failure, thyrotoxicosis, severe anemia, wet beriberi. MCQ high yield. RHF most common cause is LHF. Verapam may help HFpEF due to HCM, but avoid in HFrEF. Pressure versus volume overload to concentric hypertrophy versus dilatation themes. Question 3. Pathophysiology and compensations, cardiac reserve. Model answer. Helpful within limits, beyond that, they worsen heart failure. 1. Reflex tachycardia sympathetic. 2. Ventricular dilatation, by Frank Starling, stretch to increase contractility within the limit. 3. Hypertrophy to pressure load. Bigger doesn't mean better long term. 4. Blood flow redistribution to brain and heart from skin and splanchnic. 5. Renin-angiotensin-aldosterone system activation, leading to sodium and water retention. 6. Atrial natriuretic peptide and brain natriuretic peptide release from stretch, leading to natriuresis and vasodilation. MCQ high yield. Frank Starling law definition. RAAS versus natriuretic peptides equals opposing systems. Question 4. Clinical picture, signs, symptoms by side. Model answer. Left-sided heart failure. Forward, low CO, 7 systems. Dizziness, headache or syncope, weak pulse, low systolic blood pressure, oliguria, cold skin or peripheral cyanosis, skeletal muscle fatigue or claudication, ischemic symptoms, backward pulmonary congestion, 7 lungs, exertional dyspnea, orthopnea, paroxysmal nocturnal dyspnea, to rest, exertional cough, recurrent infections, hemoptysis, pleural effusion, pulmonary edema, bilateral basal crepitations, cardiac signs of left ventricular enlargement, localized apex, apex shifted out and down, systolic bulge, tachycardia, pulsus alternans, advanced, S3 gallop, ventricular gallop, from a flabby left ventricle, functional mitral regurgitation, pansystolic from left ventricular dilatation, features of cause, ischemic heart disease, systemic hypertension, etc. Right-sided heart failure, systemic congestion, insomnia, diaphoresis on slight activity, sympathetic, JVP increases, lower limb edema, then ascites, tender congested liver, GI dyspepsia or malabsorption leading to cardiac cachexia, especially right heart failure, pleural effusion, cardiac signs, right ventricular enlargement, 6, diffuse or shifted apex outward, systolic retraction, wide bare area, left parasternal heave, epigastric pulsation, tachycardia, tricuspid S3 gallop, functional tricuspid regurgitation murmur, mnemonic, LHF equals lung congestion, RHF equals reservoir, systemic congestion. MCQ high yield. S3 plus tachycardia equals ventricular gallop. Pulsus alternans equals severe left ventricular dysfunction. Question 5. Differential diagnosis, what mimics each side? Model answer. LHF dyspnea, orthopnea mimics COPD, obesity, severe anemia, pneumonia, asthma. RHF mimics pericardial effusion, liver cirrhosis with ascites, nephrotic syndrome. Question 6. Complications. Model answer: renal failure, liver cell failure, hepatitis C related, or cardiac cirrhosis, deep vein thrombosis, pulmonary embolism, functional mitral regurgitation, cardiac cachexia, especially right heart failure, acute pulmonary edema, stroke, syncope, atrial and ventricular arrhythmias.
Q7. Investigations. Core to advanced. Model answer: one line, scheme plus echo, EF, plus natriuretic peptide BNP or NT-proBNP. CXR, chamber enlargement, pulmonary congestion, curly B lines, short, peripheral, less than 1 centimeter. ECG, often non-diagnostic but shows cause or complications, MI, arrhythmias, or LVH. Echocardiography, key test, chamber size, wall motion, paradoxical segments, EF and SF. EF equals SV by EDV times 100, N approximately 50%. EF less than 40% leads to HF-REF, greater than or equal to 50% leads to HF-PEF. Shortening fraction, SF, equals LVEDD minus LVESD by LVEDD times 100, N 28 to 42%. LVEDD 36 to 56 millimeters, LVESD 20 to 40 millimeters. Cath, CT, MRI, or nuclear when etiology, ischemia, pressures, or anatomy needed. Labs: CBC, anemia, lipids, glucose, LFT, congestion, RFT, low CO, troponins for AHF and ACS, electrolytes, including magnesium, pulse oximetry, or ABG, TSH. Natriuretic peptides. Typical rule-out: BNP less than 100 nanograms per liter or NT-proBNP less than 300 nanograms per liter, acute presentations. Rule in: BNP greater than 400 to 500 nanograms per liter or age-specific NT-proBNP 450, 900, 1800 nanograms per liter for less than 50, 50 to 75, greater than 75 year, higher with renal failure, lower in obesity. Levels are higher in older age, women, renal failure, AF, even without AHF, can be lower in obesity and sometimes in end-stage fibrotic HF. Sample stability, exam pearl. NT-proBNP is much more stable, approximately 72 hours at room temperature, than BNP, less than 4 hours for many assays. MCQ high yield. NT-proBNP preferred in elderly and renal dysfunction, age-adjusted cutoffs. BNP low in obesity, high in AF and CKD at baseline. Q8. Management principles, chronic HF. Model answer: A. Treat the cause, IHD revascularization, valve disease, HTN, etc. B. Remove precipitants, infection, anemia, arrhythmia, drugs, diet non-adherence. C. General. Rest until decongested, semi-sitting to reduce venous return. Watch bed rest complications, psychosis, bed sores, PE, DVT, constipation, urine retention. Diet: sodium restriction 2 to 3 grams per day, fluid restriction in severe cases, small frequent meals, adequate K and omega-3, calorie control if obese. Sedation, for example diazepam, if anxious. Lifestyle: mild exercise when stable. D. Specific: drug, device, surgery. D1. Evidence-based medical therapy. Drugs with mortality benefit: ACEI or ARB or ARNI preferred when tolerated, beta blocker, metoprolol succinate, bisoprolol, or carvedilol, MRA, spironolactone or eplerenone, SGLT2 inhibitor, for example dapagliflozin or empagliflozin, benefit across EF for HF-REF and HF-PEF. Quadruple therapy early and up-titrated when possible. Add-ons, selected high-risk groups. ARNI, sacubitril/valsartan instead of ACEI or ARB if symptomatic on other therapy. Start 49-51 mg BID, total 100 mg per day, as tolerated, and double after 2 to 4 weeks to 97-103 mg BID, total 200 mg per day. 36-hour washout after ACEI, avoid with eliskerin or prior angioedema. Ivabradine, sinus rhythm, HR greater than 70 beats per minute despite max beta blocker, leads to lower HF hospitalization. Vericiguat, post-worsening HF-REF despite GDMT, leads to modest lower CV death and HF hospitalization. IV iron improves symptoms and quality and reduces HF admissions in iron deficiency with symptomatic HF. Symptom relief. No mortality benefit per se, but loop diuretics, for example, furosemide 40 to 160 mg per day PO or IV, combined with thiazide, HTCZ, or K-sparing spironolactone to overcome resistance or correct K+. Morning dosing preferred. SEs, 4 hypos, K+, volume, Na+, hypochloremic alkalosis, and 4 hypers, glucose, lipids, uric acid, calcium increase with thiazide. Loops lose calcium. Furosemide, ototoxicity or nephrotoxicity, spironolactone, hyperkalemia, and gynecomastia. Vasodilators. Venous, nitrates reduce preload. Arteriolar, hydralazine or diazoxide reduce afterload. Both ACEI or ARB or ARNI, or nitroprusside IV in AHF. Option nitroserbine diglytrate when ACEI or ARB or ARNI not tolerated. Inotropes, short-term or advanced care, dobutamine, dopamine, milrinone, levosimedan IV. Digitalis digoxin, now limited best for HF with AF, rate control, and for symptomatic HF-REF to reduce hospitalizations, no mortality benefit. Mechanism, inhibits Na+/K+ ATPase, increase intracellular Na+, increase calcium, increase contractility, vagotonic, reduces AV conduction. ECG dig effect, therapeutic, PR increase, tall R, scooped ST depression, Salvador Dali's mustache, T inversion, biphasic, QT decrease, supportive. Oxygen if hypoxemic, anticoagulation if AF or prior thromboembolism. Aminophylline rarely used, legacy. Lifestyle, vaccines, smoking cessation, salt and fluid discipline, cardiac re-education. Devices and procedures, CRT for biventricular pacing for LVEF less than 35%, LBBB QRS greater than 150 milliseconds with symptoms despite GDMT. ICD for primary prevention if LVEF less than 35% after at least 3 months of GDMT. Revascularization, PCI/CABG for viable ischemia, valve surgery, LVAD, transplant for stage D. MCQ high yield, ACEI or ARB or ARNI, beta blocker, MRA, SGLT2 inhibitor equals mortality benefit. Diuretics, nitrates, inotropes equals symptom or hemodynamics only. Eplerenone more selective than spironolactone, post-MI HF. Entresto, no ACEI overlap, 36-hour washout. 2025 EBM add-ons, know the direction of travel. SGLT2 inhibitors now Class 1 across EF in the ESC-focused update, reduce CV death and HF admissions. Quad therapy early, ARNI/ACEI or ARP plus beta blocker plus MRA plus SGLT2 per ACC/AHA/HFSA 2022. Ivabradine, Shift, and Vericiguat, Victoria, for selected high-risk HF. IV iron recommended to improve functional status and lower HF admissions.
Quad therapy, early ARNI, ACEI, ARB, plus beta blocker, plus MRA, plus SGLT2 per ACC, AHA, HFSA 2022. Ibravadine, Shift, and Vericiguat, Victoria, for selected high-risk HF-REF. IV iron recommended to improve functional status and decrease hospitalizations. Q9, acute heart failure, acute cardiogenic pulmonary edema. Model answer. Definition. Rapid onset or worsening heart failure symptoms, signs, life-threatening, needs urgent assessment and admission. Etiology/triggers. De novo, acute myocardial dysfunction, ischemic, inflammatory, toxic, acute VHD, tamponade. On chronic, infection, uncontrolled BP, arrhythmias, AF or VT or severe bradycardia, drug triggers, NSAIDs, steroids, negative inotropes, cardiotoxic chemo, COPD exacerbation, PE, endocrine/metabolic, thyroid, DKA, adrenal, mechanical complications post-MI, free wall rupture, VSD, acute MR, prosthetic valve failure, clinical, severe dyspnea at rest, orthopnea, sense of impending death, sweating and irritability, cyanosis, crepitations, frothy pink sputum. Look for ACS features. Bedside hemodynamic profile, congestion versus perfusion, warm-wet, most common, cold-wet, cold-dry, warm-dry, compensated, hypoperfusion signs, cold sweaty extremities, oliguria, confusion, narrow pulse pressure, e.g. 80-65, congestion signs, pulmonary crackles, LL edema, high JVP, tender hepatomegaly, investigations, BNP/NT-proBNP recommended in acute dyspnea triage to distinguish cardiogenic from non-cardiogenic causes, diagnostic, prognostic, and monitoring roles. CXR, pulmonary edema, consider widened mediastinum, aortic dissection. ECG, rarely normal, rapid AF, acute MI, echo immediately if hemodynamic instability or cardiogenic shock, labs, troponin, urea/CR, electrolytes, glucose, TSH, ABG. Treatment, initial hospital or ICU. 1. Position and monitoring, semi-sitting, O2 saturation, IV access, urine output. 2. Oxygen only if SpO2 less than 90% or PaO2 less than 60 mmHg. Consider NIV if persistent hypoxia or distress. Routine oxygen not required if normoxemic. 3. Loop diuretic IV, e.g. furosemide 20 to 40 milligrams, bolus plus minus continuous infusion, up titrate to response. Combined thiazide in resistant cases, sequential nephron blockade, acetazolamide add-on can accelerate decongestion, Advor. 4. Vasodilators IV if SBP greater than 110 millimeters of mercury, nitroglycerin infusion, sodium nitroprusside, 0.5 to 5 micrograms per kilogram per minute, unit. 5. Inotropes for hypotension or low output, dobutamine, dopamine, 5 to 10 micrograms per kilogram per minute, inodilators, milrinone, levosimendan, if on beta blocker, or to improve contractility/VD. 6. Vasopressors, e.g. norepinephrine, if shock persists despite inotropes. 7. Antithrombotic prophylaxis, LMWH. 8. Treat cause/precipitants, ACS, infection, arrhythmias, PE, thyroid. 9. Advanced measures for refractory cases, CRT, ICD, primary prevention later, IABP, selected mechanical complications, mechanical ventilation, LVAD, transplant. Practice update. Morphine is no longer routine. Respiratory depression, increase ventilation risk. Consider only for severe anxiety or refractory dyspnea with monitoring. MCQ high yield, warm-wet equals commonest AHF profile, BNP/NT-proBNP recommended in acute dyspnea triage, nitroprusside dose is micrograms per kilogram per minute, not milligrams. Q10, HFpEF diastolic, diagnosis and therapy. Model answer, diagnosis, same symptoms/signs as HFrEF, but EF normal. Evidence of diastolic dysfunction, structural heart disease, or elevated filling pressures. BNP/NT-proBNP may be elevated despite preserved EF. Treatment. Treat the cause/comorbidities, HTN, IHD, diuretics for congestion, ACE inhibitors, ARBs or RNI, beta blockers decrease heart rate to increase diastolic filling, BP control, LVH regression, non-DHP CCBs, verapamil, can be effective in HCM-related HFpEF, exam favorite, no role for positive inotropes or digoxin in typical HFpEF. SGLT2 inhibitors reduce HF events in HFpEF as well. MCQ high yield, HFpEF equals stiff ventricle, HTN number 1 cause. Verapamil helpful in idiopathic HCM diastolic failure.
Question 11. Refractory intractable HF, causes and plan. Model answer. Definition. Persistent or quickly recurrent decompensation despite optimal therapy. Why? Diagnostic error, example pericardial effusion, poor salt restriction or drug discontinuation, precipitant unremoved, uncontrolled cause, example hypertension or AS, or end-stage HF. Management. Reassess and fix cause, remove precipitant, strict bed rest, salt and fluid restriction, aggressive but rational diuretics, consider continuous IV inotropes, CRT, ICD, ventilation, transplant, especially young, LVEF less than 20% after full measures. Q12. Prognosis and Egyptian insights. Model answer. Outcomes vary by acuity and system. In the ESC-HF long-term registry, including Mediterranean countries, 1-year mortality approximate 23.6% for HF versus 6.4% for chronic HF outpatients. Composite death by HF hospitalization approximate 36% versus 14.5%. Egypt data. Regional registries, example Delta HF, highlight high in-hospital and early post-discharge mortality in HF, underscoring gaps in GDMT uptake and BP and arrhythmia control. Prognosis tracks NYHA class, BNP, NT-proBNP, renal function, SBP, LVEF, iron deficiency, and comorbidities like diabetes, AF, and CKD. Early deployment of quadruple therapy plus device therapy when indicated improves survival. MCQ high yield. Predictors, renal function, SBP, NP levels, NYHA, LVEF. Post-HF 1-year risk remains high despite discharge. Lists you must write in seconds. Flash MCQ notes. Side by side. Left HF, dyspnea sequence, crepications, pink froth, pleural effusion. Right HF, JVP increases, edema to ascites, tender hepatomegaly, cachexia. Right ventricular enlargement, 6 signs. Diffuse apex, apex shifted outward, systolic retraction, wide cardiac bare area, left parasternal heave, epigastric pulsation. Loop versus thiazide. Loops lose Ca2+, thiazides save Ca2+. Thiazides aid to hypercalcia. Digoxin ECG. PR increases, scooped ST, Dali's moustache, T inversion or biphasic QT decrease. BNP/NT-proBNP. Rule out BNP less than 100, NT-proBNP less than 300, rule in BNP greater than 400 to 500, or NT-proBNP 450, 900, and 1800 by age. NT-proBNP stable around 72 hours RT. Acute dosing units. TRAP. Nitroprusside in UKG per minute, dopamine UKG per minute, not milligram. Short essays mapped to likely exam questions. 1. Discuss the classification of heart failure and the clinical and structural staging systems. Use Q1 template. 2. Enumerate the etiologies of left and right HF and outline precipitating factors. Use Q2 list, include 3x3 tables, highlight RHF most commonly due to LHF. 3. Describe the compensatory mechanisms in heart failure and their hemodynamic limits. Use Q3 points. 4. Write the clinical picture of left and right HF, including special signs. Use Q4, don't forget pulses, alternans, functional MR or TR, RV6 signs. 5. List the complications of HF. Use Q6 bullet list. 6. Outline the investigations in HF, including EF/SF calculations and natriuretic peptides. Use Q7 with formulas and normal values plus NP cutoffs. 7. Give a detailed account of chronic HF management, including drugs with mortality benefit. Use Q8, quadruple therapy first, indications CI for ARNI, ivibradine, vericiguat, IV iron. 8. Acute pulmonary edema causes, clinical features, bedside profiling, investigations, and management. Use Q9. Mention oxygen only if SpO2 less than 90%, diuretic first, vasodilators if hypertensive, and inotropes if hypotensive, morphine not routine. 9. Diastolic heart failure with preserved ejection fraction, HFpEF, causes, diagnosis, and management. Use Q10 include HCM verapamil pearl, SGLT2 class benefit. 10. Refractory HF, differential causes and stepwise management. Use Q11. 11. Prognosis in HF and regional Egypt-MENA considerations. Use Q12. Quick reminders: drugs that reduce mortality, ACEI or ARB or ARNI, beta blockers 3, MMAR, SGLT2 inhibitors, selected ivabradine or vericiguat in appropriate patients. Drugs without mortality benefit, symptom or hemodynamic, diuretics, nitrates, vasodilators, IV acute, positive inotropes, oxygen only if hypoxic, and morphine avoid routine. Diuretic adverse effects: 4 hypos and 4 hypers. Loops lose Ca2+, thiazides increase Ca2+, furosemide ototoxic, spironolactone, gynecomastia. Digoxin when to use: HF plus AF's rate control, symptomatic HF ref to reduce admissions, avoidant tamponade, constrictive pericarditis, pure ischemic disease without AF, isolated MS, pulmonary disease dominant RV, HCM/HFpEF with poor compliance. Classic exam list.